So Sarah and I are going to talk a little bit today about marketing attribution, which some of you may or may not be familiar with that term, but really it's just measurement, right? How can healthcare marketers prove what they're doing is actually working, is actually bringing in the people that they want to bring in? So I'm going to start. I'm just going to share a little bit of an agenda. We'll go through that pretty quick, nothing, too exciting. But what we can't prove, right? I'm going to start with what we can't prove. So we obviously know there's things that we do that really there's no way for us to tell what it's doing. How, who is it bringing in? Is it bringing in the right people? Is it bringing in the wrong people? How do we measure certain things? And the honest answer is there's certain things that we just can't measure. So of course that leads us into the beauty of a CRM product, right? And how we can target the right people. And then of course bring that back around to measurement. And then of course answering the age-old phrase or question of how do we know they wouldn't have come in anyway, right? And we'll get into that. I have a slide dedicated to that because that's a big question that we get. Success criteria reporting, so that's really our version of how to measure something differently than just who's coming in, who's not coming in. There's sometimes the goal of a campaign isn't just to drive, specific people. Sometimes the goal of a campaign is to shift payer mix. Sometimes the goal of a campaign is to, just fill a doctor's practice with whoever, just to get them full, and then maybe focus later on getting the right people in. And then Sarah, I'm going to pass it off to Sarah for some case studies and then, of course, some Q&A at the end. So what we can't prove. We're all familiar with this image. We all know what this is, right? We all do billboards. We've seen them before. But how many people saw this billboard and then came into your hospital for cardiac care? Unless we're asking everybody every time they have a visit, why'd you come here? Did you see a billboard? Did you hear a radio ad? We have no idea, right? We have no idea if someone saw this billboard and thought, oh, I'm going to go to that hospital. I love that billboard. And then who saw this ad for an ortho seminar and came to that event and then furthermore had a joint replacement seminar? Had a joint replacement procedure. How are we following those people around? Are we able to say how many people saw this ad? Not technically, right? And again, unless we're asking people, and a lot of times, right, when they're coming to events, we are asking them how they came. But then are you tracking that? Are you keeping track of those measurements further? Probably not, right? And who saw this guy on TV and thought, I need to schedule an appointment with a PCP? Again, we don't know who's seeing that TV commercial. We don't know what their payer type is. We just don't know much about them, right? We don't know we know who we are looking to target maybe geographically, but specifically who's seeing that ad, we don't really know. So of course I'm going to get into the beauty of a CRM. So those 3 marketing tactics are very common, right? Something that, again, all of you who are hospital marketers probably have to do. And I'm not telling you to make them go away. That's probably not even feasible for most of you. But what I am saying is that some of those dollars maybe can be shifted to a more highly targeted audience, right? So maybe taking some of those billboard dollars and using it to find the people who are most likely to need cardiac care in your service area that are good payers, right? And targeting them, maybe with a direct mail. And then again, being able to track them back, and we'll get into the tracking part here in just a minute. Or taking that joint replacement seminar ad in the newspaper and using some of those dollars to do an automated phone call out to those very high qualified ortho targets, right? People who are most likely to need or use the service or come to the event, and sending a robocall out saying, hi, this is Rockdale Medical Center. We're having a joint replacement seminar on June 20th. We'd love for you to join us. Press 1 to register for the event. And the really cool part about having a CRM product is not only can we track the people that we called and see what they did, we can also track the people who called the call center to register and see what they did. And then we can also track the people who actually came to the event because, right, we know a few people are going to fall off of that list. any data point, and again, some of you may have a CRM and some of you may not, but if you do, feeding any point of data into that CRM so you're able to measure it. I always tell clients that you shouldn't just be measuring the campaigns that you're pushing out through the CRM. You should also be measuring any other campaigns that you have data through. So HRAs, web forms, affinity group lists, classes and event registrations, any call center data you have, all of that can be fed back into a CRM, and you can actually see how any of those things are performing via your CRM, which is really cool. So it's not just used for the campaigns that are pushed out through it. And then, of course, using that TV, or taking some of those TV dollars and shifting them to a more highly targeted email, right? So maybe finding the people, instead of putting out a TV commercial saying we have PCPs accepting new patients, finding those people in your service area that don't have a PCP, they're good payers, or maybe we're doing a radius around a specific clinic that those doctors practice at, and we're saying, hey, this doctor's accepting new patients. Here's a link to his 2-minute bio. Watch it if you like him. Either click here to make an appointment or request an appointment, or call this number to get scheduled. So like I said, I dedicated a slide to, but they would have come in anyway, right? We always get that question, how do I know that they wouldn't have come in anyway? And the answer is, we don't. We don't know that they wouldn't have come in anyway. And I just really quickly want to address the control group thing, because most CRMs, and I've worked for a couple other CRM vendors in the space, most of them were or are measuring against a control group, and that's okay. However, any of you statistically minded people out there like myself, a control group really is not valid at a 95% rate with 2% error, which again is a statistic term, but it's not valid unless you have 2,600 respondents. Now you think of a control group being about 5 to 10% of a targeted list. To get 2,600 respondents in a control group, it would just have to be a huge campaign. And that really gets away from that micro-segmentation that a CRM product offers, right? Because we're trying to find a small group of people to target for the right services at the right time, by the right medium, right? And so it really goes against that. So we're getting away with a CRM, we're getting away from that, what we call spray and pray, right? Spray the market, pray that the right people come in. Now we're just going straight to targeting the right people and knowing that anybody that responds to that is going to be a good respondent. So the shift is to focus on metrics like actual dollars, payer mix shift, and conversion rate. So again, feeding your patient data back into the CRM system, you're going to be able to actually see metrics like dollars, contribution margin, expected net revenue, things like that. Whatever financial metrics are what you guys measure on. You know, a lot of them measure on contribution margin, so I use that one as an example a lot. And then, of course, conversion rates. You know, what matters? What was the goal of that campaign? Was it to just convert people to become a patient of that new doctor to fill his practice or her practice? Or was the goal to get better payers, right, into a specific clinic because they have so many, you know, bad payers, as we refer to them? So, of course, driving contribution margin up and getting good conversion rates of good, positive payers makes doctors and admin very happy. So I'm going to get into how we kind of talk about, you know, getting away from that control group reporting to more of a success criteria reporting, which is what we refer to it here at Tea Leaves. So I always ask clients when they start a campaign, what's the goal of this campaign? Because let's set the success criteria to make sure we're measuring specifically on that, right? Because we can all push out a campaign and measure, you know, we can all push out a reminder to get your colonoscopy, but then did they actually come in and get that colonoscopy? So I just put up a few examples up here that I can kind of talk through so that you'll kind of understand the different ways that we can measure that are getting away from, again, just specifically that control group reporting. So mammography, right? We're pushing out, and this is something Sarah does, pushing out mammography reminders to women, you know, turning 40, maybe they're lapsed. Maybe it's just a reminder they had one, you know, 11 months ago, and you can see that in your data, reminding them, hey, it's time to get back in, just to keep them loyal, right? and targeting the right payer mix. So now we're gonna measure just the women who had a mammogram, or maybe we care about mammogram, excuse me, plus downstream procedures. So we care about mammograms, mastectomies, any biopsies, things like that. Maybe all of that's important. And so we can measure any way, whatever is important to your organization is how we'll measure. So now we can see conversion rates of how many women we actually asked to get a mammogram versus how many actually did, and of course that contribution margin and those dollars tied to that. I mentioned a new doc, so looking to get volume to a new doc. So there, of course, we care about conversion rates, but getting him the right volume is obviously going to keep him engaged and happy. And create less turnover. So, and being able to show those doctors, which I have found it has been huge, especially the last couple of years it seems like in this space, being able to show those doctors what a CRM can do for them and who you're targeting and how you're targeting the right people is huge, right? Because we all know that we joke at tea leaves that MD behind a doctor stands for marketing director because they all think they're one. But, we have to play into that a little bit, right? Being able to show them that we're targeting the right people and driving the right people to their practice is a big thing for them. New location, kind of the same thing. What are those conversion rates? Maybe you opened a freestanding ER. How do we target the people that are most likely to use it, right? Again, using that CRM system, being able to find households with children, being able to find those who have chronic diseases that are maybe using the ER more often than not or more often than they'd like to. But again, just being able to target the right people, the right payers, and bring them into this new location. I just had a client say to me, we have this new location, it has to do well. We have to get the right people in there. Great, then CRM is a perfect tool to get the word out about this specific location. Hip and knee seminar. So this one is really, I like this one because it's really like really well-rounded. You can talk really well about it CRM-wise because it really kind of goes through the full spectrum, right? We find the right people in your database to target for the seminar. We send them an email. We send them a direct mail. We call them, whatever it is that you decide to push out for communication. Maybe 100 people register for that hip and knee seminar, but only 75 show up. So now we're gonna track the 5,000 we mailed, we're gonna track the 100 that registered, and we're gonna track the 75 that actually showed up. So we're able to track all three levels, seeing what they actually did. So what happened after that? After they got the direct mail or email or phone call, after they registered, what did they do? After they actually came to the seminar, what did they do? Did they actually have a hip or knee replacement? And again, we can set the success criteria that specifically to say, I only care about the people that actually had a hip or knee replacement. Or maybe you care about the people that visited an ortho doc at all. So maybe we say, hey, anybody who visited these 4 orthos, I want to track them. I want to see what they're going to do. And then my personal favorite, bariatric online video seminar. And this is my favorite because, again, it's just one of those cool concepts that I think has really taken off amongst our clients is if any of you are doing bariatrics or have bariatrics in your practice and you do a seminar, I really encourage you to videotape it and then pay someone to edit it down to 20 or 30 minutes and put it on your website. The kicker being that they have to fill out kind of a web form, a mini web form to get to that video, because then we're able to track those folks. We're able to see exactly who those folks are that filled out that form to watch that video. And did they then come in for a consult, or did they come in for, your weight loss program, or did they come in and start the bariatric surgery process? So pretty cool. Again, if any of you are doing bariatrics, highly recommend it. It's very successful. I've now seen it probably done 7 or 8 times across the last 10 years and just been incredibly successful. There's a little bit of work that goes into it, of course, but it pays off in the end. And then I just stress one more time that you can look at conversion rates and financial data. So we're not just talking about, we can look at both of those things at the same time. It doesn't have to be one or the other. So I can see the conversion rates of that new doc, or I can see the conversion rates for that new location. And at the same time, I can see the contribution margin. I can see the expected net revenue if I care about those, right? Again, sometimes that's not the goal of the campaign. I can also see the payer mix on every single respondent. One of my favorite things to show clients is that here's what your typical payer mix looks like overall, because we have all your patient data. Here's what your typical payer mix looks like, and here's the payer mix of the people you're targeting and the people that are responding, which is just a really cool shift to see, right? And a really cool shift to show admin. So I'm going to pass it off to Sarah. She's going to share a couple case studies. Sarah's been doing CRM for about 3 years now. And some of these campaigns have been running for the duration. So I'm going to pass it off to her and let her talk about a couple of her successes.
So good morning. I'm Sarah Teach. I'm with Rockdale Medical Center. And today I'm going to talk about 2 of our, 7 campaigns that we run through Tea Leaves. The first one that I want to talk about is what we call our ER redirect or ER misuse. And really what triggered this is, like many organizations, we have individuals who are coming in for low acuity complaints and really would be better served in an urgent care situation. So what we have done is, working through Tea Leaves, we've executed a monthly automated campaign that targets individuals who had certain diagnosis criteria, that discharge data is downloaded into Tea Leaves. And so we target them with a direct mailer, educating them about our urgent care centers. So what we have found, measuring only visits to those urgent care locations, our campaign's been sent out to just over 1,600 patients. 211 patients then had a visit at one of our urgent care locations. Another data point that we didn't put in here, and I was thinking about this morning, is also showing encounters. So of these 211 patients, we've had nearly 400 encounters from those individuals. So showing a pattern of those individuals now utilizing the urgent care as opposed to the ED. So this gives us that response conversion rate that we're looking for of 12.6%, which is pretty high, and generating a contribution margin of $40,000. So this, as a marketing director, as Jaci was talking about, that spray and pray mentality, this actually allows me to go back to my administration as well as my board members and show them, we have a marketing spend, these are the dollars that you've budgeted for us, but this is what we're actually contributing back to the bottom line of our organization. The second case study goes to the mammography. So one of the things that we wanted to do was target women who are turning 40 to get them established with our organization before they become established with another one, because once they're having that mammogram in a place, they're more likely to return to that same organization. So again, partnering, we execute a monthly campaign, and it goes out to women who will be turning 40 in the next month, letting them know that now's the time to start having that annual mammogram. So the campaign's been sent out to just over 3,200 individuals, and this includes people who have been patients at Rockdale before, not necessarily for anything to do with mammography, but just in some way have touched our system. And then also non-patients, so we call those friends and family and pure prospects. We've had 339 respondents, and our measuring criteria for this campaign is simply a screening mammogram. So this does not include any downstream procedures such as biopsies or mastectomies. So our conversion rate for this campaign has been 10.3%, which is pretty phenomenal. And then on this one, we like to measure our ROI, because again, that's something that as a marketing director is very important for us to be able to report back to administration. And so seeing an ROI of $9.52 for every $1 spent, and then again, just measuring that on the screening mammographies. And then this is going back to what Jaci's talking about our payer mix, being able to show, again, the board members the type of patient that we are targeting. And of course, the majority of these patients you can see do have commercial and managed care. You'll notice some have Medicaid and some are self-pay. And that is basically, Jaci and I've talked about this numerous times, people's situations change. So someone may have gotten that postcard in the mail, and maybe they had employment or insurance through an employer, and then by the time they've come in for that mammogram, that situation has changed. But so you do see but you'll see the majority of those who have responded are in that commercial and managed care. So any questions?
Could you talk specifically about how you are, just some of the mechanics of how you're tracking the responses? Are you getting like a nightly download from Revenue Cycle? Sorry. Are you getting like a nightly download from Revenue Cycle? And then on the contribution margin, the way we're doing it right now, we have to then send it back to our finance department to run the contribution margin. Are y'all actually doing the contribution margin?
So there's a couple different ways that clients do it. So I'll tell you that we can take updates as often as daily. I'll be honest in saying that it's usually hindering because of cost, right? Because it's very costly to be updating every single day patient data within your application. Most clients send a monthly fee. So every month we're getting that, we typically do like a rolling 3 months, right? So that financials can catch up and resolve themselves because, right, everybody doesn't pay right away and things like that. So we're typically doing a rolling 3 months of data. Every single month we're getting that upload. And with your contribution margin question, there's a couple different ways that clients do it. Some send it right in the file so that we know, this visit, thank you. We know that this visit was it had this much contribution margin, right? We're able to say, right, their finance department does all the calculating, and there's just a column that says contribution margin, and we tie that back. We have other clients that actually just say to us, hey, we're going to be really conservative and say that 3% or 5% of all charges are contribution margin. And then we do that calculation for them on the back end. So there's a couple different ways. Yep.
And then my question for Sarah, do you have, I'm assuming your physician groups and your hospital are all on the same EMR. Is that how you're tracking? Well, you didn't actually give an example of physician appointments, but one of the things we struggle with is our employed physician groups and our hospital are not on the same EMR yet. We're in a conversion right now. But so we can track hospital encounters, but you talked about, visits to an orthopedic surgeon. Does that really only work well when they're all on the same EMR?
No, our EMRs are different. The hospital's on Meditech, and my physician practices are on ECW. I do think that probably, and I'm going to go out on a limb here and say that being LifePoint, and that's actually, so all that information is actually coming from our corporate office. So it's a data dump between the two. And then they're pulling that from that one source at LifePoint.
And I can just say that we typically, there's never just one EMR source that we're getting from clients. There's at least 2, if not 4 or 5. So that's never a problem as far as how many EMRs or data sources that you're sending in. The more the better, honestly.
Okay, good, thank you.
Mm-hmm.
I have a question, a couple of questions. On the campaign, or on the case studies that you did, Sarah, were they just a one-time mailing, and then was it a mailing with just print, or did that also include electronic? These have been ongoing campaigns. The mammography campaign, I believe, has been running for about 2 to 2.5 years. The ED misuse campaign has been running for right around a year, maybe just a little under a year. They do mail out monthly. And what was the rest of your question? I'm sorry. I was trying to think. If there was print, or if it was print and electronic?
No, we've only done print for our market.
Okay. Okay. And so when you gave the numbers of the people that it was mailed out to, that's the amount that it's mailed out to monthly, on a monthly basis, or that's the total?
That's
over
the total that it's
Okay.
been mailed out.
Okay, thank you.
So, to that point, it just shows, right, that it's very, very highly targeted. So over 2.5 years, she's only sent that many.
Right.
So they're very small groups, because we're really looking for that very specific target of women that are turning 40, or that very specific target of people who have come into their ED for a headache or a stomach ache or, a UTI or something that they maybe should just be using in urgent care for. So, that's why those groups are so small.
Do you ever incorporate electronic correspondence into, and do you see that to be as successful as print?
So that's a great question. And yes,
Thank you.
No, go for it.
Sarah, I see you're also in charge of business development for Rockdale, and the person I talked to from Tea Leaves the first night talked about how a lot of people use that for business development to, just figure out where you're going to put new access points. Do you use it for that as well?
We don't. We have not at this time. But what we have done, really, when I talked about a little bit more of the business development, is we've used it in bringing on new docs. So we've had a new GI come on board. And so in growing his patient volume, kind of going back to what Jaci was talking about, we've been targeting very specific individuals, certain payer mixes, wanting to grow his business. And in that, looking at very specific geographical areas. And so I guess sort of from an overall, trying to grow in more of our secondary service area for the hospital through his practice.
Okay, thanks.
Any other questions? No? All right.
All right.
Thanks, everyone. Thanks for coming.